Hi everybody, welcome to my YouTube channel Dr.Sreenivas Medical Concepts and my FB page Dr.Sreenivas Concepts. This is Dr. Sreenivas, neurologist from Andhra Pradesh, India. I am also the medical author of the book Focused Neurology. Today we are going to talk about a very interesting topic, one of the common disorders, stroke. The stroke neurology in nutshell. In fact, the neurologists and other doctors learn neurology stroke by stroke. Stroke neurology in nutshell. Stroke is one of the common causes of death. In fact, it is one of the three most common causes of death. The other two being myocardial infarction and cancer. And therefore, all the medical professionals need to know about stroke. Stroke is an acute focal neurological deficit due to vascular cause. So it has basically three important features. It is acute, it is focal, and it is due to a vascular cause. The strokes are broadly divided into two categories, ischemic stroke and hemorrhagic stroke. Ischemic stroke is because of the decreased blood flow. It amounts to about 85% of all stroke patients, and hemorrhagic stroke is because of the rupture of the vessel and seepage of the blood, which accounts to about 15% of the stroke patients. But to understand stroke and all the important concepts of stroke, we need to understand the circle of Willis, the blood supply to the brain. In fact, the blood supply to the brain is very generous in the form of circle of Willis. It is an arterial anastomosis between two vascular territories, the internal carotid artery and the vertebro-basilar territories. So it forms a circle, and therefore if one vessel gets blocked, blood can go from the other vessel and then compensate it. Despite this wonderful protection, stroke is the second or the third commonest cause of death after myocardial infarction and cancer. Imagine if this protection were not to be there, perhaps stroke would have been the commonest cause of death. So stroke, to understand stroke, we need to know the circle of Willis. As I said, it is an anastomosis between the vertebro-basilar system, what we call as posterior circulation, and the internal carotid arterial system, what we call it as anterior circulation. The two vertebral arteries join together to form basilar artery. If we know these important concepts, it is easy to approach a person suffering from stroke with confidence. So the two vertebral arteries join together to form basilar artery, and therefore the vertebral artery supplies the medulla oblongata. So the medulla oblongata of the brainstem is supplied by the vertebral artery, and therefore the vertebral artery gets affected, medulla oblongata gets affected. So 9, 10, 11, 12 cranial nerves get affected, and there will be opposite hemiplegia. One of the common syndromes what we encounter in medulla oblongata is Wallenberg syndrome, the lateral medullary syndrome, wherein except the posterior column and pyramidal tract and peltina, which are placed medially, except those three structures, the other structures of the medulla oblongata are affected. The second is the two vertebral arteries join together to form basilar artery. So basilar artery basically supplies pons. So pons is supplied by the basilar artery. So we have 5, 6, 7, 8 cranial nerves in the pons. So there will be ipsilateral 5, 6, 7, 8 cranial nerve palsies with contralateral hemiplegia. That means it is pons. One of the common brainstem syndromes we encounter in relationship to pons is Milliard-Gubler syndrome. The basilar artery divides into two posterior cerebral arteries. So the midbrain is supplied by the posterior cerebral artery. So the third, fourth cranial nerves get affected on the same side with hemiplegia on the opposite side. It indicates a midbrain lesion. One of the common syndromes we encounter in the midbrain is the Weber's syndrome. So the medulla oblongata is supplied by the vertebral artery. The pons is supplied by the basilar artery. Midbrain is supplied by the posterior cerebral artery. The posterior cerebral artery winds around and supplies the temporo-occipital cortex. This is about the posterior circulation. Now let's see the anterior circulation. The internal carotid artery gives rise to the middle cerebral artery and the anterior cerebral artery, which are joined by the anterior communicating artery. The middle cerebral artery further divides into two main arteries, the superior and the inferior divisions of the middle cerebral artery, but before that it gives a penetrating arteries known as the lenticulostriate arteries. So from the internal carotid artery comes the middle cerebral artery, the anterior cerebral arteries, which are joined by the ACOM, anterior communicating artery. So now let's see what happens. So the middle cerebral artery supplies the entire cortex, especially the lateral surface, and therefore if the middle cerebral artery gets affected, almost the entire cerebral cortex gets affected except the medial part, which is supplied by the anterior cerebral artery, and the posterior part, which is supplied by the posterior cerebral artery. So if the middle cerebral artery gets affected, the entire cerebral cortex gets affected except the medial part, the leg area, the bladder area, which is supplied by the anterior cerebral artery, and the occipital cortex, which is primarily responsible for vision, which is supplied by the posterior cerebral artery. Other than the occipital cortex and the medial part of the frontal lobe, the entire cerebral cortex is supplied by the middle cerebral artery. Very important. The cerebellum, finally. The cerebellum is supplied by the posterior circulation. It is supplied by the posterior inferior cerebellar artery of the vertebral artery, and two arteries from the basilar arteries, ICA, anterior inferior cerebellar artery, and superior cerebellar artery from the basilar artery. If we know these broad concepts, the basic structures and the arteries, the main arteries which supply these structures, we can approach a person with stroke confidently. So this is the overview emphasizing the brainstem, the medulla oblongata is supplied by the vertebral artery, pons by the basilar artery, midbrain by the posterior cerebral artery, and the temporo-occipital cortex is also by the posterior cerebral artery. The cerebellum is supplied by the pica, posterior cerebellar artery of the vertebral artery, superior cerebellar artery and anterior inferior cerebellar arteries of the basilar artery. The entire cortex is supplied by the middle cerebral artery except the medial part of the frontal lobe, the leg area and the bladder area, which is supplied by the anterior cerebral artery, and the occipital cortex, which is supplied by the posterior cerebral artery. Right. So circle of Willis is one of the important concepts to understand stroke. The second important concept to understand stroke is homunculus. Motor homunculus and sensory homunculus are almost same. The representation of all the body parts in the brain is not according to the quantity, it is according to the quality. The more delicate our movements are, the more the representation in the brain. So if we see the leg and the thorax, they are area wise they are big, but then the representation is very small because we hardly use our thorax and legs also only for a limited movement of walking, but we keep using our fingers. In fact, the manual dexterity and the language and intelligence differentiates the human being from other animals. So the way we use our fingers is very significant. The way we manipulate our fingers, we keep using our face for facial expressions and for other purposes. So the quality, the usage of the fingers and the face are more, and therefore the representation of the hand and face has got the greatest representation, whereas the leg and thorax has got a very minimal representation. The leg area is in the medial part of the frontal lobe supplied by the anterior cerebral artery, but the other parts are supplied by the middle cerebral artery. So an important point is that the face and the hands has got the maximum representation, and therefore they tend to get involved easily, and the leg and the thorax has got a minimal representation in the brain. Very important concept. Right. Now let's see the individual arteries, the middle cerebral arteries. The middle cerebral artery gives rise to two peripheral main divisions, the superior division of the middle cerebral artery and the inferior division of the middle cerebral artery, and before that they give perforating branches, the lenticulostriate arteries, especially to the internal capsule. So the middle cerebral artery gets affected, the main arteries, that is superior division and the inferior division, can get affected, as well as the lenticulostriate arteries get affected. So now let's see the clinical manifestations. If the middle cerebral artery gets affected, now let's focus on the superior and inferior divisions, the main divisions of the middle cerebral artery. If they get affected, as I said, the entire cortex is supplied to the middle cerebral artery, and therefore the middle cerebral artery, example on the left side, gets affected. Patient will have contralateral. For example, in this particular case, it will be right hemiparesis and sensory impairment. The hand and face are more affected than the leg because the leg area is supplied by the anterior cerebral artery. So there will be contralateral hemiparesis and sensory impairment. There will be contralateral homonymous hemianopia because of the optic radiations gets involved. They'll have contralateral or homonymous hemianopia. And then we have frontal eye fields area number 8, which pushes the eyes to the opposite side. And therefore, when the frontal eye fields area number 8 gets affected, it cannot push the eyes. Eyes will move to the same side as that of the lesion. We call that as gaze preference. So they'll have gaze preference or ipsilateral gaze palsy. Then there are two important functions of the left side of the cortex and the right side of the cortex. The left side of the cortex is primarily concerned with the language, and therefore if the left MCA gets affected, they'll have aphasia. Whereas the right side of the cortex is basically concerned with the spatial orientation. So if the right parietal cortex gets affected, they'll have left hemi-neglect. Whereas if the left parietal lobe gets affected, they will not have right hemi-neglect. What is the mechanism? The right side of the cortex controls both the right and the left extrapersonal space, whereas the left cortex controls only the right extrapersonal space. So if the left cortex is affected, the right extrapersonal space is affected, which is compensated by the intact right parietal lobe, which controls both the right and the left. So the left parietal lobe lesions do not produce right hemi-neglect. But if right parietal lobe gets affected, both the right and the left are affected. The right is compensated by the intact left, but there is no compensation for the left side. So right parietal lobe lesions develop left-sided hemi-neglect. How do we test this at the bedside? We ask them to put a clock with 12 numbers over the entire clock. But a person who's got left hemi-neglect will put all 12 numbers only on the right side, completely neglecting the left side. So the left side of the cortex produces language disturbances. It could be motor aphasia, that is Broca's aphasia, or sensory aphasia, Wernicke's aphasia, or conduction aphasia, subcortical aphasias, or conduction aphasias, or global aphasias, depending upon the area which gets affected. Whereas if the right cortex gets affected, they'll have left hemi-neglect. So these are the primary important features of the middle cerebral artery. We are just focusing on the important concepts. Suppose the lenticulostriate arteries of the middle cerebral artery gets affected, they will supply the internal capsule. So all the fibers, corticospinal fibers, are very close together in the posterior limb of the internal capsule. So a small lesion there can produce a dense hemiplegia. See, the motor is separate, the sensory is separate, so they can get individually affected. So they can have pure motor hemiplegia, or close by there is thalamus, only thalamus can get affected. They can have pure sensory hemesthesia. Pons, these are lacunar infarcts. So internal capsule supplied by the middle cerebral artery, which produces the motor or pure dense hemiplegia. But other lacunar syndromes are pure sensory, where the thalamus gets affected. Pons, in pons you have the frontopontocerebellar fibers going, and therefore if the pons gets affected, they'll have ataxia. The seventh nerve is also in the pons, so they cannot close their lips with orbicularis oculi, so they will develop ataxic hemiparesis or dysarthria, clumsy hand syndrome. So these are all the lacunar syndromes: pure motor hemiplegia, pure sensory hemesthesia, dysarthria, clumsy hand syndrome, and ataxic hemiparesis. But the internal capsule, the predominant supply is by the lenticulostriate arteries of the middle cerebral artery. We can divide internal capsule into upper half and the lower half. The upper half is predominantly supplied by the middle cerebral artery. The lower halves we can divide into three parts: AC, PC, AC. Anterior choroidal artery, a branch of internal carotid artery; posterior cerebral artery; and then the other AC is the anterior cerebral artery, a branch of which is a Hemorrhagic artery. So, but predominantly internal capsule is supplied by the lenticulostriate of the arteries of the middle cerebral artery, and if they get affected, they'll have dense hemiplegia because all the corticospinal fibers are close together in the internal capsule. Another important concept: How do we differentiate between a cortical MCA stroke and between the internal capsule MCA stroke? If the cortex gets affected because of the MCA stroke, both the motor and sensory get affected because they are supplied by the same blood vessel, middle cerebral artery. So they'll have hemiplegia, hemesthesia and homonymous hemianopia. All the three get affected. Whereas in internal capsule, they have individual blood supply. For example, motor, it is supplied by the lenticulostriate arteries of the middle cerebral artery. Sensory, it could be PCA. So they can have a pure motor hemiplegia or pure sensory hemesthesia. But if they are combined together and if there are other associated features of cortical involvement, we think of a cortex involvement. If it is internal capsule, it could be pure motor or pure sensory hemesthesia. And then there could be homonymous hemianopia here also because the optic radiations go just underneath the internal capsule. So hemiplegia, hemesthesia, homonymous hemianopia, it could be an internal capsule lesion. Hemiplegia, hemesthesia, homonymous hemianopia, but associated with other features is a cortical lesion. Right, this is about the middle cerebral artery. Anterior cerebral artery. As I said, the anterior cerebral artery supplies the medial part of the frontal lobe where we have leg area and the bladder area. So if both the anterior cerebral arteries gets affected, both the legs gets affected, they can have paraplegia. One important cerebral cause of paraplegia is an anterior cerebral artery stroke. So they'll have leg area being affected more than the face and the hand area. They can have urinary incontinence. And anterocerebral artery also supplies the frontal area, so they can have frontal release signs, sucking reflex, grasp reflex. These are the reflexes which are present in infancy. But as the child becomes mature, these reflexes have to disappear. Persistence of these reflexes indicates that the brain has not matured or the brain has matured but again deteriorated. So these reflexes should be present in infancy, but they should disappear after infancy, which indicates the maturity of the frontal lobe. Carotid stroke. The internal carotid artery divides into middle cerebral artery and the anterior cerebral artery, and it gives rise to ophthalmic artery also. So if an embolus lodges into the internal carotid artery and goes to the ophthalmic artery, they may develop a characteristic amorous fuel gas. It is a blindness, it is like a curtain of blindness coming from upwards downwards. So if there is an amorous fuel gas, it indicates an impending carotid artery stroke, and therefore we need to be vigilant. We need to do ultrasound and angiogram and see how much stenosis is there. If it is more than 70%, we can get intervention done like stenting or endarterectomy. Posterior cerebral artery stroke. The posterior cerebral artery supplies the midbrain where it can produce brainstem syndromes like Weber syndrome, or it comes and supplies the temporo-occipital cortex. So the temporal lobe gets affected, they'll have memory impairment. If occipital lobe gets affected, they'll have homonymous hemianopia with macular sparing because macula is supplied by both MCA and PCA. Another interesting feature, especially if the left posterior cerebral artery gets affected, is alexia without agraphia. Alexia, difficulty in reading without agraphia, so there is no difficulty in writing. This can be explained by left posterior cerebral artery stroke. The language area is on the left side. If there is a left posterior cerebral artery stroke, the left occipital cortex gets affected, and therefore whatever vision has to take place to be converted into a language form has to come from the right occipital cortex. But left PCA supplies not only the occipital cortex but the splenium of the corpus callosum also, and therefore the information cannot be transferred from the right occipital cortex to the language area on the left side, so they have difficulty in reading. They don't have difficulty in writing because for writing we don't need vision. From auditory cortex, it goes to the vernix area where it understands and goes to the motor cortex, they can write. We can close and write also. So they'll have alexia without agraphia. They have difficulty in reading but no difficulty in writing. In fact, persons who have just written with their own handwriting can't read it. This is known as alexia without agraphia. So all the right sided vision goes to the left occipital cortex. It is easy to convert whatever is there on the right side into language form because the right side goes to the left occipital cortex. The language area is on the left side, so it easily accesses. But anything on the left goes to the right occipital cortex. It has to cross the splenium of the corpus callosum and go to the left occipital cortex and then the language area. So if there is a lesion in the splenium of the corpus callosum, it cannot be transferred to the language area. So left posterior cerebral artery, because of the lesion of the occipital cortex and the splenium of the corpus callosum, the vision part cannot access to the language area which is on the left side. So this is known as alexia without agraphia, one of the important concepts. Right. Now let's go to the hemorrhagic stroke. Generally, when a person has got stroke, we ask for non-contrast CT scan. Generally, other conditions like tuberculoma or neurocysticercosis, where we expect a blood-brain barrier to be broken down, we ask for a contrast CT. But here we ask specifically non-contrast CT scan. Why do we ask non-contrast CT scan for stroke patients? Because when we give contrast, it can just go and then it can appear hypertense, and we may mistake it to be having hemorrhage. And therefore, in stroke patients, we prefer a non-contrast CT scan so that we don't get confused with the hemorrhagic stroke, which also appears hypertense. One of the important causes for hemorrhagic stroke is chronic hypertension, which damages the penetrating arteries, producing Charcot-Bouchard aneurysms. And these are the end arteries which are characteristically seen in putamen, thalamus, pons, and cerebellum. So what are the clinical features? The clinical features are that of the focal neurological deficit and the raised intracranial tension. If the putamen gets affected, the internal capsule is close by, and therefore they have features of hemiplegia. If thalamus gets affected, they'll have sensory hemesthesia, because the thalamus is the area where all the sensory fibers go and integrate in the thalamus. So if the thalamus gets affected, contralateral hemesthesia. Thalamus is very close to the midbrain, so it can go and impinge on the top of the midbrain, where we have the vertical gaze center, especially the crossing up gaze fibers gets affected. So they cannot look upwards. So in thalamic hemorrhage, they'll be looking downwards, because it goes and impinges the top of the midbrain, where we have the crossing up gaze fibers. And then the hypothalamic fibers, the sympathetic fibers for pupillary dilatation, also originate near thalamus, hypothalamus. So when they get affected, pupils cannot dilate. So pupils will be small, myotic pupil, eyes looking downwards, hemesthesia or sensory disturbance on the opposite side. We have the diagnosis, it is thalamic hemorrhage. If the pons gets affected, both the sympathetic tracts get affected, because we have one basilar artery supplying the pons, unlike midbrain where we have two posterior cerebral arteries and medulla oblongata where we have two vertebral arteries. In pons we have a single basilar artery, so that ruptures, blood seeps bilaterally, both the sympathetic tracts gets affected. So it is bilateral Horner's syndrome, so they'll have pinpoint pupil. Pons is responsible for horizontal eye movement, so oculocephalic reflex gets affected. Pons is also responsible for corneal reflex. 5th and 7th nerves are there, so corneal reflex will be absent or diminished. And the RAS is also close in the pons, so if it gets affected, person may be drowsy and losing consciousness. So these are all the signs of fontanine hemorrhage. Pinpoint pupil, horizontal eye movement getting affected, vestibulo-ocular reflex, loss of consciousness, or the reticular activating system gets affected, the consciousness gets decreased, and corneal reflex being absent. And then finally cerebellum. If cerebellum gets affected, they'll have ataxia, imbalance, because cerebellum is responsible for balance. They can have nystagmus. But we have to be carefully watching out on cerebellar hemorrhage, because it's a highly treatable condition. We can get the help of the neurosurgeon and can surgically evacuate cerebellar hemorrhage. So if we find hemorrhage in these four sites, putamen, pons, thalamus, cerebellum, it is because of hypertension. Not only they produce focal neurological deficit, because of the blood, it starts accumulating and goes and compresses the brain. The overlying skull cannot accommodate the extra volume, so there will be raised intracranial tension. One of the important clinical signs of the raised intracranial tension is headache, because of the meningeal involvement, and persons will have drowsiness or decreased in sensorium. So decrease in sensorium, headache always indicates that they are developing signs of raised intracranial tension. Right. Venous stroke. Like arteries, we have the venous drainage of the brain. One of the important veins to get affected in the venous stroke is superior sagittal sinus. Superior sagittal sinus thrombosis is very, very common. A very important concept in venous stroke is that in arterial stroke we treat with antiplatelets, but venous stroke we have to treat only with oral anticoagulants, because venous strokes are because of red thrombus. There are no platelets involved in venous stroke. It is because of hypoperfusion or slowness of the perfusion. And because of that, according to Virchow's triad, and when there is slow blood flow, it forms into a clot. There are no platelets, there are only fibrins and red blood corpuscles, hence the name red thrombus. Since there are no platelets, there is no role for antiplatelet therapy. For venous strokes, we have to give oral anticoagulants. That is the dictum. We give heparin as a bridging therapy followed by oral anticoagulant therapy, and it has got a wonderful prognosis as compared to arterial strokes. Persons come with an unconscious state, but the moment we give heparin oral anticoagulant, they recover completely well. So prognosis wise, venous strokes fare far better than arterial strokes. So venous strokes, we have to give only anticoagulants. There's no role for antiplatelets, and they have a wonderful recovery. Venous strokes. And another important concept of venous stroke is that they tend to produce hemorrhage because of the back pressure. But this is one condition, perhaps the only condition, where despite there being hemorrhage, we still give heparin and anticoagulants. So despite being hemorrhage in venous stroke, we still give anticoagulants, oral anticoagulants and heparin. We have to give, then only the person will recover. So these are all important concepts. And usually this is seen in women, especially persons who are taking oral contraceptive pills or pregnancy or postpartum. Postpartum venous strokes are more common because of the deficiency in the natural anticoagulant substances like protein C, protein S and antithrombin 3. Whereas in pregnancy, arterial strokes are more common because of the increase in the procoagulant factors. So the presentation of venous stroke is because of the raised intracranial tension again. So they'll have headache, they'll have decrease in sensorium. It goes and irritates, so they produce seizures. They can have superior sagittal sinus, so it affects the leg area, so they can present with leg weakness. Because of the raised ICT, they'll have decrease in sensorium. So despite hemorrhage, we have to treat with anticoagulants, and the investigation, we do MRI with venogram, we can see the block. One of the common causes of cortical venous strokes is the superior sagittal sinus thrombosis, which can be picked up by MRI venogram. We have seen the hypertensive hemorrhagic stroke. Now, what are the non-hypertensive hemorrhagic strokes? First is the cerebral amyloid angiopathy. It is usually seen in old people. It is usually seen in lobar hemorrhage, and it is associated with amyloid deposition. So it can be seen in Alzheimer's disease also, usually more than 65 years of age. And when we take scan, either there is lobar hemorrhage or microbleeds all over. Another important non-hypertensive hemorrhage is arteriovenous malformation, AVM. Generally, when there is artery, it becomes arteriole, capillary, venule veins. So between the artery and the vein, there is intervening capillary network. If there is no intervening capillary network and there is a direct communication between the artery and vein, we call that as an arteriovenous malformation or AVM. It is usually seen in young people. They present with seizures. And how do we diagnose it? They present with seizures. How do we diagnose it? When we do imaging and when we give an agent, it appears early. An early filling or early dilatation of the vein is a very characteristic feature of AVM, because it takes a lot of time for normal people for it to appear from the artery, arterioles, capillary, venules and veins. But when there is no intervening capillaries, the dye or the material appears directly from the arteries into the veins. So early filling or early dilatation of the vein is one of the characteristic features of arteriovenous malformations. We have to give anti-epileptic drugs and take a neurosurgeon's help. Subarachnoid hemorrhage. Subarachnoid hemorrhage because of the artery, because of the arterial dilatation known as aneurysms. It could be because of the aneurysms or because of the trauma. They rupture and cause hemorrhage. So hemorrhage is in the subarachnoid space because the circle of Willis is in the subarachnoid space. So as long as it is in the subarachnoid space and does not seep into the brain, there are no focal neurological deficits. In fact, one of the classic presentations of subarachnoid hemorrhage is severe excruciating headache but no focal neurological deficits, as the brain is not affected. But why is there headache? Because brain is not sensitive to pain. Even if the brain is cut, there is no pain. But the meninges and meningeal vessels are highly sensitive to pain. They have pain structures. So anything which infects or inflames or irritates meninges, there will be severe pain, like meningitis and subarachnoid hemorrhage, where the meninges are affected. So severe headache, severe excruciating headache, especially after physical exertion like playing games or involving in a physical relationship, causes severe excruciating headache without localizing focal neurological signs. Yeah, we can diagnose it by CT scan. If we do not pick up, we can do lumbar puncture where we can see the CSF mixed with blood. We can see xanthochromia also. The sites of the subarachnoid hemorrhage, the aneurysms are more in the anterior circulation, especially at the bifurcation. So the anterior circulation, the aneurysms are more commonly seen in the anterior circulation than the posterior circulation. It is seen at the bifurcation. Sometimes we can just pick up the site by just clinical findings. For example, if there's a posterior communicating artery aneurysm, it goes and impinges on the third nerve. So there is no pupillary constriction, pupillary dilatation is there. So sometimes by just clinical signs, we can make out which vessel is affected. So aneurysms are the dilatations of the arteries. It is usually because of aneurysms or trauma, they rupture causing subarachnoid hemorrhage. They produce a severe headache, excruciating headache, thunderclap headache, sometimes associated with no neurological findings, no focal neurological findings. In medical treatment, we give nimodipine to prevent vascular spasm because of the blood substances. They irritate and produce vasospasm. So to prevent it, we give nimodipine. We can get a surgeon's or a radiologist's help and do coiling and clipping of the aneurysm. So these are all the important concepts, overall concepts of the stroke neurology in nutshell. I hope you have enjoyed listening to my lecture. If you have any suggestions or comments, kindly post on to my YouTube channel. But please like and subscribe my YouTube channel, Dr. Sreenivas Medical Concepts, and my FB page, Dr. Sreenivas Concepts. Thank you. Bye.